So catheter ablation is an invasive procedure where we're trying to take away the triggers and alter the substrate within the heart, within the atrium, to increase the likelihood of maintaining sinus rhythm. So that procedure involves normally a day in hospital and a night, and they go home the next day. Tubes is normally done either under conscious sedation or general anaesthetic. Tubes are inserted into the leg, and through those we position catheters inside the heart, cross over to the left-hand side, and then either using balloons, cryo balloons, or catheters to do point-by-point ablation, we isolate the pulmonary veins to take away the triggers causing the atrial fibrillation, and then if necessary go on to do further ablation, all with the hope of maintaining sinus rhythm. So the first contact that we'll get with the patient will be a GP referral letter. That will be obviously reviewed, and if it's discussing an AF patient, then the first things that we do would be to organise for an echocardiogram to be done before they come to the clinic. Then they'll have a 24-hour tape Holter monitor, so a monitor to record their heart rhythm over 24 hours. And then when they come to the clinic, they'll be given a quality of life AF questionnaire to help us assess how their palpitations and their arrhythmia affects their daily life, and also their concerns about that arrhythmia. Patients with paroxysmal atrial fibrillation, so that's patients having attacks of AF that are relatively short-lasting, they are the patients who do best with catheter ablation, and often they're the patients who have most troublesome symptoms compared to patients who are in atrial fibrillation all the time. I think if a patient's having severe symptoms that seem likely to be caused by their atrial fibrillation, then they should be referred at that point. If they've been tried on a number of drugs, perhaps without much effect, then they should definitely be referred. And if there's any concern that the atrial fibrillation might be related to underlying heart disease, that should definitely be looked at. It depends obviously on the individual patient. One thing that is clear is that at the moment atrial fibrillation is a procedure done for reduction in symptoms rather than to reduce the risk of stroke. Even if the patient has quite a low risk of stroke when they go for the ablation, because we're putting burns inside the atrium, they will have to be anticoagulated for a period of time after the ablation. So they'll have to be on anticoagulation, normally warfarin, for a period of time after the ablation. Well, there's a nurse-led AF arrhythmia clinic, so often they're the first point of contact if they're not coming to the consultant-led clinic, and separate to formal clinic appointments, our team, primarily with the arrhythmia nurses, run support groups where patients with AF can get some support and discuss their symptoms and treatment options at regular times during the year. If it's a patient who ends up getting an AF ablation, we'll see them perhaps 3 months after the procedure, and then depending on what the outcome is, we may see them at 6-month intervals for a period up to a couple of years, and then if they're well, then discharge them. Or if they get referred to the clinic and we decide not to go for an ablation treatment, we might alter their tablets or alter the way that their atrial fibrillation is dealt with, and then refer them back either to their local cardiologist or to their GP.